Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is polymyalgia rheumatica. So what is polymyalgia rheumatica, or PMR for short? This is a common inflammatory disorder of the elderly and comprises a subacute onset of severe stiffness and pain, mainly in the proximal joints and muscles, without any objective weakness. It's associated usually with a high ESR. This tends to affect patients who are older than 50 years, with a male to female ratio of approximately 2:1. The disease is more common in Caucasians. So as we mentioned, this is characterised by symmetrical shoulder aching of greater than 2 weeks, as well as bilateral pelvic girdle pain. Both of these don't have to be present in the same patient in order to make a diagnosis. You may have one or the other. Patients tend to report morning stiffness lasting longer than 45 minutes, and they may also be constitutionally unwell. So this just harks back to what we were saying in that introduction episode to vasculitis, that a lot of these conditions are characterised by one or more of fever, malaise, weight loss. And the condition may also present as GCA, and that's just something to be really wary of because the two conditions do lie on a spectrum. And as we've seen, GCA can lead to some severe complications such as visual loss. So it's just important to be aware of that. Examination findings reveal limited range of hip and shoulder movement. And as we've said, it's really important to examine for GCA findings in these patients, even if they don't report any headache, for example. So always good to just check for scalp tenderness and visual changes. And this is just something to bear in mind, particularly when you're doing your PACES examinations. Investigations comprise, as usual, the bedside tests and then going on to more complex tests. So in this case, you would do the bedside tests as for GCA. So you do a blood pressure and also check a urine dip. Good to check for those things as well, just in case you're suspecting an infection, which can be a mimic of the constitutional symptoms, particularly that are seen in PMR. You then go on and do some blood tests such as ESR and CRP, which are often raised in this condition. The full blood count may show an anemia, and one should also check antibodies such as ANCA and rheumatoid factor to again check for differential diagnoses and mimics such as an ANCA-associated vasculitis or a new diagnosis of an inflammatory arthritis. These blood tests will usually be negative if it's a primary polymyalgia. And finally, it's good to do an eye examination if you are suspecting giant cell arteritis. As we've said, the PMR and GCA subtypes do sit on a spectrum, and actually 50% of patients with GCA do have PMR. In a similar way, 15 to 20% of PMR patients will go on to develop GCA. The treatment of PMR comprises steroids, which usually starts at a dose of 15 milligrams once per day with a gradual taper downwards. Usually patients remain on steroids for a year, but this can be more if they do relapse. It's important to counsel patients on where to go and who to approach, so that their most approachable medical professional or acute services if they do feel like they're having a relapse, so that blood tests can be done as soon as possible, the patient can be examined, and then the steroid dose can be increased back to the last effective dose. This is also important just in case they are developing GCA if they've previously had PMR, so patients should be counselled accordingly. As we've said, steroid dosing will be long-term, therefore it's important to prescribe a PPI to prevent the onset of gastritis, as well as bone protection, particularly as this patient demographic are older and so are at risk of osteoporosis as it stands anyway. So this bone protection can be given with calcium and vitamin D supplementation, as well as a bisphosphonate such as weekly alendronic acid. And just based on that, it's also good to consider a DEXA scan in these patients as well to check baseline bone density. So now on to some questions. Which of the following is typically strongly positive or high in titer in a patient presenting with signs and symptoms concerning for PMR? So your options are ESR, creatinine kinase, ANCA, rheumatoid factor, or a creatinine. So the correct answer here, as you'll recall, is a high ESR. Don't be fooled into thinking that these patients have a high CK level. This is not true. High CKs are seen in the inflammatory myopathies, which we've previously discussed. Second question, in a patient with confirmed diagnosis of PMR, which of the following medications is not usually required? So your options are ibuprofen, Ascal D3, alendronic acid, omeprazole, and prednisolone. And you'll remember that prednisolone is the mainstay of treatment, and there are other medications that need to be given alongside that, given the long duration of treatment, and therefore ibuprofen is the correct answer here. Patients should not typically require strong forms of pain relief in addition to their steroids, as the steroids should be settling the symptoms. If they don't, you need to be looking for a PMR mimic. This can include severe infections and malignancies, including a myeloma. Thank you for listening to this episode of Bite-Sized MRCP. If you like the sound of what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you'd like to hear from us about in the future, and see you in our next episode.